Um, this evening's teleworkshop, Getting a Diagnosis and Talking to Your Physician. I'll be here to moderate, and I am Jan Robson, Program Coordinator at the Alzheimer's Society of BC. But we have a special guest tonight, so you're not forced to listen to myself or to Mark Lebrecht tonight for a change. Instead, we have Dr. Douglas Drummond. We're pleased to welcome him this evening. Dr. Drummond is on staff at the Specialized Seniors Clinic in New Westminster and was formerly the director of the Geriatric Assessment and Treatment Unit at the University Hospital in Prince George, and this was for about 7 years. He's on the Dementia Education Project's Planning Committee, which is aimed at educating physicians about dementia, and is also Clinical Associate Professor, Department of Family Practice at UBC. So we're very pleased to welcome him here this evening, and I'm sure that you'll be able to get a wealth of information in the next hour. Welcome, Dr. Drummond.
Thank you very much, Jan. So at these public forums on Alzheimer's disease, we often hear from the public that they knew that their family member was developing something, but they had a difficulty in having the diagnosis of Alzheimer's disease confirmed. So that's what we're going to talk about this evening. Now, Jan,
up the steer.
Yes,
there you go. Good.
So we're talking about getting the diagnosis and talking to the doctor or health practitioner. The topics for discussion tonight include how does a practitioner actually make the diagnosis of Alzheimer's disease? How can a patient and family ensure that a timely diagnosis is made? How you should present information to health practitioners, and how you can come away with the information that you need. So just, first of all, some basics about Alzheimer's disease. You probably know this already, but Alzheimer's disease is caused by the buildup in the brain of a protein called amyloid. And as the amyloid accumulates, it becomes toxic, and brain cells start to die off. But the important point is that this disease process has likely been going on for some 10 to 15 years by the time that the diagnosis is made. So the diagnosis, there are 7 stages in Alzheimer's disease, but the diagnosis can only be made at the beginning of stage 4. So on this slide, if you can see it, there's a picture of Ronald Reagan, the former president of the U.S. Now, Ronald Reagan ultimately developed Alzheimer's disease, but during his 2 terms in office, he likely would have had either stage 1 or stage 2 Alzheimer's. And he didn't know that, nobody else knew that, and he was merrily running the Western world. But if he had died, and if they had done an autopsy, they would have seen the amyloid starting to build up. Now the next stage, stage 3, coincides with what we call mild cognitive impairment, that I'll refer to as MCI. And that stage of MCI lasts for 1 or 2 years. So this is a stage in which the patient and certainly the family are likely to be aware that there are memory problems developing. But you can't confirm the diagnosis of Alzheimer's disease during MCI, or as we might call it, stage 3, because the person doesn't yet meet the diagnostic criteria for Alzheimer's. So that's part of the problem in the delay in diagnosis, is that you can see it coming for quite a while before the diagnosis can actually be confirmed. So you might well ask the question then, can technology make the diagnosis for us? And to some extent, yes, it can. So there are fancy scans like PET scans and tests that can be done with spinal taps that can tell us which of those people with MCI might actually be headed on to Alzheimer's disease. In fact, although that technology exists in a research setting, it's not available to us street-level clinicians. And for the most part, it doesn't make a lot of difference, since we don't yet have any treatments for Alzheimer's disease that would actually stop the accumulation of amyloid or to prevent the death of brain cells. So here is the progression that occurs from normal cognition through MCI, or mild cognitive impairment, and on to Alzheimer's disease. The diagnosis of MCI and the diagnosis of early Alzheimer's disease are made by clinical diagnostic criteria. So that means the appearance of the patient and what we learn from the history and asking questions. It's not like a condition, say, like diabetes, where there's a simple test, blood sugar, and if your fasting blood sugar is 7 or greater, you've got diabetes, and if it's below 7, you don't have diabetes. We have no easy, concrete, objective criteria like that for diagnosing Alzheimer's. So the diagnostic criteria that we use are these. We say that a person has Alzheimer's disease if they have deficits in 2 areas of cognitive function. Well, there are essentially 3 principal or major areas of cognitive function. The first being memory, short-term memory in particular. The second being speech, so we're looking for loss of speech fluency, difficulty finding words and putting them together. And the third is executive function. So the executive functions of the brain are things like organizing type behaviors, problem solving, planning, reasoning, multitasking, insight, judgment, social behavior, etc. So there have to be deficits in at least 2 of those 3 areas, memory, speech, and executive functions. And, importantly, there has to be at least some loss in the ability to independently perform the activities of daily living. So there has to be memory decline, other cognitive decline, and there has to be impact on your ability to live independently. Things like working, driving a car, managing your finances, keeping your household organized, taking your medications, traveling about, etc., etc. And you can see how sometimes this could be difficult to tell whether a person meets that criterion. So, for instance, if a person is younger and still working, it's likely to show up much more readily. But what we're sometimes faced with is elderly people who no longer do any challenging activities. They no longer drive, they no longer work. Perhaps they've handed over the management of finances to one of their children. So sometimes it can be difficult for us to tell if there is, in fact, any deficit in the ability to live independently. Let us give you a case history. I'm going to tell you about a make-believe patient, Marjorie, age 78. I'm actually going to tell this story twice with different outcomes. So Marge is a widow who lives alone in an apartment. She's actually fairly fit for her age, and she is living independently, doing everything for herself, driving a car, shopping, managing her finances, etc. She has a daughter, Barbara, who lives nearby with her husband and children. They talk on the phone every evening. So one evening on the telephone, Barbara says to her mother, well, Mother, you know, you just asked me that question a few moments ago, and I told you the answer. Do you not remember? And she said, oh, I'm sorry, dear, I think I mustn't have been paying attention. And Barbara says, well, this has been happening more and more, Mother, and I'm starting to get worried, so I think you ought to take this problem to the doctor. So after some persuasion, Marge agrees to take the problem to her doctor. She says, well, I happen to have an appointment next week because I need to go in and have my blood pressure checked and get my prescriptions renewed, and I'll tell her then. So dutifully, Mother goes to see the family doctor the next week, and as usual, she presents the doctor with her home blood pressure readings, which they've been monitoring. The doctor has had some blood tests done before this visit. She's been monitoring the blood sugar level, which has been getting borderline, so they discuss that, discuss her diet. The doctor renews her prescriptions for her. Marge mentions about the knee pain she was talking to the doctor about last time and said those exercises haven't really done anything for me. So the doctor orders some x-rays of the knees, and on it goes. So as the family doctor moves to end the visit, Marge adds, is there anything you can do about my memory? And the doctor says, well, what sorts of problems are you having with your memory? And Marge replies, well, I go to another room to get something and I can't remember what I came for. Sometimes I bump into an old neighbor on the street and I can't remember their name. And sometimes I get stuck for a word. So the doctor asks What sort of mistakes have you made because of your poor memory? Have you made any serious errors, such as getting lost while driving? And Marge replies, oh no, nothing like that. It's just annoying. And the doctor says, well, I shouldn't worry. It all sounds quite common and normal. Let me know if it gets worse. And that's the end of the visit. So why don't we replay this visit in a slightly different way and see if we get a different outcome. So this time around, Barbara says to Mother, you've asked me that question already. I'm starting to worry about you. I'm really quite concerned, Mother. Would it be okay if we make a special visit to your doctor to discuss this? Marge isn't convinced. Well, I suppose so. But mind what you say. I don't want you letting my doctor think I'm a blithering idiot. Barb senses her mother's resentment at this interference and knows that when they go to the doctor's office the next week, that she's likely going to feel quite uncomfortable telling the doctor about some of the things she's observed. So what she does is she drops off a note at the doctor's office the day before the visit, explaining that she won't be able to speak freely, but she wants the doctor to know a few things. So for instance, the note says, Mom has had to have her bank card PIN number reset 3 times because she keeps forgetting it. She had trouble keeping track of bills, so Barb had to have them put on automatic payment. She's had 2 minor fender benders this year, and Barb no longer feels comfortable letting her drive the grandchildren home from soccer practice or ballet. Barb invited her for dinner one evening, and she showed up on the wrong day. Recently, she tried to bake cookies for the grandchildren, but the cookies turned out wrong because she had left out some of the ingredients. So the family doctor, prepped by this information, doesn't involve Barbara, doesn't ask Barbara any questions, but asks Marge some questions, knowing where the problems are, asking things like, have you been having trouble managing bills and banking, handling medications, problems in the kitchen, burning pots, trouble with recipes, any trouble with driving, accidents or mishaps, etc. Marge admits to some of the failings in Barb's note, but dodges other ones. She minimizes these other ones. Well, the doctor says, well, Marge, let's give you a little screening test for memory. And she administers the Montreal Cognitive Assessment, or MOCA. And Marge scores 21 out of 30, which is below the normal expected range. Not a terrible score, but somewhat low. So the family doctor says, well, come back next week, and we're going to do a full physical exam. And in the meantime, I'd like you to have some blood tests done, routine blood tests. And she says to Barb, the daughter, we'll meet again for another visit after that, and I'd like you to be present for that visit. And at that visit, the doctor discloses a diagnosis of Alzheimer's disease to Marge and Barb. She gives them some written literature. She refers them to the Alzheimer's Society First Link program for further education and support. And she discusses options for treatment and for referral. So what do you think about this? We had the same patient, the same doctor, but 2 different outcomes. So how did that come about? Well, to get the best outcome from the doctor's visit, one thing is that if you want the doctor to take the problem seriously, make a special visit. Don't try to tack this problem onto a laundry list of rather mundane items. Let the doctor know that you consider this problem to be serious by making a special effort with it. Also, when you go to the doctor's office, go prepared. Think about what the doctor might ask you and have your thoughts organized and ready, or better still, make a few written notes when you go. You know, as a physician, I've often had patients come to me with problems and say, patient comes with a chest pain, and I say, well, tell me about the pain. What's it like? Oh, I don't know. It's just a pain. How long have you had that pain for? I don't know, a while. It certainly leaves you the impression that this is likely not a serious problem because the patient himself hasn't taken it very seriously. Now, in the case of cognitive disorders such as MCI or dementia, it is difficult and often impossible to make the diagnosis without the observations of an insightful family member. And I know when I'm doing consultations on people coming from memory problems, when I look in the waiting room and see the person sitting there on their own with no family member, I know that I'm going to have a difficult time making this diagnosis. And there are two principal reasons for that. People with early cognitive disorders will often minimize their symptoms. Seniors fear loss of independence. They especially fear things like losing driving privileges and being put in nursing homes. They don't want the world to see their failings. And they feel humiliated by an appearance of regression to a more childlike state. So in this case, probably Marge felt rather humiliated by having her daughter taking her to the doctor. She probably hasn't been taken to the doctor since she was 14 years old, especially by somebody whose diaper she used to change. Now, the other issue that often makes the diagnosis difficult, getting the history difficult, is what some people call denial, but probably shouldn't be called denial. That's where people with early Alzheimer's disease are blissfully unaware that anything is happening to them. Denial, strictly speaking, is a psychological phenomenon whereby somebody blots out something that is too painful to accept. That's not the problem here. The problem is with insight, the ability to recognize what's happening with you, to recognize your failings. And insight is one of those executive functions, and I mentioned that 3 areas of cognition go in Alzheimer's disease, at least go first, and that's memory, speech functions, and executive functions. So probably a majority, if only a small majority, of people with early Alzheimer's disease have absolutely no awareness of what's happening to them. And I see that all the time. I'll say to the patient, well, what brings you to see me today? They'll say, I don't know. I guess it's my memory. I don't think there's anything wrong with my memory, but my family says there is. And then the family will go on to tell me all sorts of horrible mistakes they've been making because of their poor memory. What we need to do as health professionals is to differentiate benign forgetfulness from serious forgetfulness. That is to say, forgetfulness that has consequences, forgetfulness that's threatening loss of independence. So for instance, the family doctor, when Marge came to see her and said, well, I go from one room to another to get something, and I get there and I can't remember what I came for, and I run into an old acquaintance on the street and I can't remember their name, you can just tell that the family doctor is thinking, well, okay, now tell me something that I haven't personally done in the last week or so. These are common phenomena that we all have. So we have to figure out who is having just simple, benign forgetfulness that we might all be prone to, as opposed to serious forgetfulness with consequences. So it helps when we have a family member telling us that there is this pattern of failing due to memory, because we often can't rely on the senior themselves to tell us this. And if you can't speak freely in front of your family member to tell us about this, then you've got to find some other way of letting us know. You wouldn't be doing us any favor or your loved one any favor by letting us be deceived. Now, I often get this question from the public: how do you handle denial? How do you handle the person who doesn't think they have a problem and refuses to go to the doctor about it? And it's a hard problem. Now, generally speaking, we say don't try to force the issue. This isn't like a cancer where early diagnosis is going to be critical in curing the disease. If the diagnosis should be delayed by 6 months or a year, there's no huge harm that's being done. And generally speaking, trying to browbeat the person into going for attention usually just drives them farther away. Sometimes we've been known to use driving privileges as a bit of a lever here. I confess I've done this in the past, where somebody may be coming down with Alzheimer's disease according to the reports of the family, and they're driving. And so I send a note to the Department of Motor Vehicles saying, not take away their license, no, just that they need a medical assessment if they're to continue driving. So that's one way of getting people to come for medical assessment when they otherwise perhaps might not. And of course, the family can talk to the doctor, their own doctor, the patient's doctor, and probably establish that there's a high likelihood that this is Alzheimer's disease, and start getting themselves educated about how they can help somebody with Alzheimer's, especially ensuring their safety. So things like making sure that the kettle has an automatic shut-off on it, making sure there are smoke detectors in the kitchen, making frequent visits to the individual, and making regular phone checks. So another question we get quite often is, should everybody insist on going to a specialty clinic like ours for Alzheimer's disease? And the answer could be yes, and the answer could be no, depending on the circumstances. Now, there's a huge variety out there among family doctors. Some have practices that have a lot of elderly people in them, and they may have done extra training in care of the elderly, and they may be perfectly capable of diagnosing and managing Alzheimer's disease. Others have practices that are heavy on the maternal child medicine, and they don't see that many older people and may not be that familiar with the conditions of later life. So it depends on that, and it depends on geography, because in some parts of this province, there are so few family doctors that essentially if something isn't actively bleeding, it just doesn't get any attention. That might be a case where we do want referrals. On the other hand, another problem is that in some parts of the province there really aren't any specialists involved in dementia care. So there's no hard and fast rule about this. Certainly we run into complex cases of dementia where even we have difficulty arriving at an exact diagnosis. So those cases are very likely to be referred, where there's difficulty in actually determining whether this is or is not dementia, or what kind of dementia it is. Another issue is that making the diagnosis of Alzheimer's disease or dementia isn't even half the battle. It's really what you do after the diagnosis that's important. It's that aspect of chronic disease management that's important. So chronic disease management is something we refer to in medicine these days, whereby people with certain chronic diseases, and let's take diabetes as an example, we recommend that they go to the physician for dedicated visits for their, say, diabetes in this case, on a regular basis, usually about every 6 months or so. And at these dedicated visits for their condition, there's nothing else on the table. There's no other conditions that are discussed at those visits. And the physician has time to go through a checklist of all the things that need to be done for that condition. And it's that kind of approach we like to see for Alzheimer's disease and dementia, that the patient come for a dedicated visit with nothing else on the table for that visit, so that it can be discussed at sufficient length to do it justice. Again, let me say to you, preparation is the key. Before you go for such visits, you want to make sure that you write down, preferably, the various things that you've noticed and the various things that you want to bring up, the questions that you have, so these issues don't get lost in the shuffle, as it were. So let me tell you what I look for at the regular visits, usually when we're following up on dementia cases in the specialized seniors clinic. This is how I structure my 6 monthly visits for dementia. There are 5 things I try to canvass at each visit. The first is the medical status. So since the last visit, have there been any important changes in the person's medical status? Have they had trips to the hospital, admissions, changes in their medication? Because some changes to medications may have an impact on dementia and dementia care. So for instance, perhaps you've been sent to some other kind of specialist about some unrelated problem, and they started some new medication, which seems fine to them in their sphere of practice, but we realize that medication may have an impact on the memory. The second area is change in cognitive function, so that's simply a matter of asking patient and family, has there been any significant change in memory and speech and so on. More importantly, the third aspect is the functional status. So that is to say, is there any change in the person's ability to manage their own personal needs on an independent basis? So are you now needing to give assistance to the patient with things that they used to be able to do for themselves? Dressing, grooming, bathing, taking their medications, or can you still go out and leave the person alone at home, or is that no longer safe to do? The fourth cardinal area would be what we call in the business BPSD, or behavioral and psychological symptoms of dementia. So these are the various non-cognitive functions of dementia. Things like agitation, delusions, mood changes, angry outbursts, etc., etc. And it's often the BPSD that gets our patients into trouble more than anything else. It's one of the things that burns out caregivers faster than anything else. And that is the fifth area, which is caregiver stress. So the person who's living most closely with the person with dementia, how are they managing? How is their health? And how are they coping with the stresses of being a caregiver? Other things I do at dedicated dementia visits, I weigh the patient. Now that's particularly important if the patient is still living alone with dementia, because such people very commonly lose weight. They underestimate their need for food. Also, some of our dementia drugs can, as a side effect, take away appetite, so we monitor weight. I would do an MMSE test. That's a mini mental state exam test. That's the common, simple test that we do for memory. I do that at each of these 6 monthly visits just to track the progression of the disease. If we have been treating a patient with one of our cholinesterase inhibitor drugs, that's drugs like donepezil and galantamine and ribostigmine, if we have been treating them with these drugs, then we need to renew the special authority for pharmacare so that the drug continues to get paid for. And importantly, we want to review what community resources are being used with the patient. So for instance, do they need home support workers, whether that's for bathing assistance or whether it's for respite care, whereby somebody may stay with the patient for a half a day a week so that the principal caregiver can go off and do things on their own and look after their own needs. And if necessary, is the patient attending one of the adult day programs that the various health authorities run? Has there been any discussion around the eventual need for going into residential care, as that's going to be essential basically in all cases eventually? And has there been ongoing involvement with the Alzheimer's Society? Have the caregivers gone through the usual educational steps offered by the Alzheimer's Society? So just a few final thoughts on communicating with physicians and other health practitioners, and then we can take some questions. It's best if you appoint a family spokesperson to be the consistent point of contact with the doctor. It's always somewhat unpleasant for the doctor if they go through a long discussion and explanation with one of the children of the involved person, only to have another one of the children call a few hours later and want you to go through all the same information again. So have a family spokesperson who is the consistent contact between the physician and the family. The next item is that we need to maintain respect for the patient who has the dementia. Although we depend very much on the input of family members, and probably much of the important information we're going to get is from the family members, we don't want to talk around the patient as though they're not even in the room. So I will commonly, ask simple, concrete questions of the patient, alternating with more complex, abstract questions to the family member to keep them feeling like they're still involved in this process. Don't be afraid to say dementia or Alzheimer's disease. We should be open about that, but not blunt. It's very unusual that we would diagnose Alzheimer's disease or dementia these days without telling the patient that. We talk about the Alzheimer journey and it's hard to be on a journey anywhere if you don't know what the destination is or what the pathway is. So we tend to be open about referring to it as Alzheimer's disease or dementia. Finally, in communication, you might want to try what I call the echoing technique, whereby you essentially summarize what you've heard. And I use this myself in practice. So let me give you an example that a patient comes and says, I have chest pain. And I ask a whole series of questions, and then I might say to the patient, so tell me if I've got this right. You're telling me that you've got this pain in the front of your chest that sometimes goes up into your throat, and it tends to come on, especially when you're walking uphill, and you've been experiencing this for about 2 months. Is that right? And then they can, of course, correct you if you've got something wrong. And likewise, the patient at the end of the visit might say to you, so let me see if I've got this right. You're telling me that this pain in my chest might be from blockages in my heart arteries, and that you're going to send me for a treadmill test so that we can find out.
Oh, we have 19 resource centers around the province that are available to give you information, education, support, referrals. The Dementia Helpline is available, this slide is an old slide. It's actually available Monday to Friday from 9 a.m. to 4 p.m. It's at 1-800-936-6033. That's a toll-free number. In the Lower Mainland, the number is 604-681-8651. The Alzheimer's Society offers various workshops around the province, including these teleworkshops. Now, some of our old teleworkshops are archived on our website in a shortened version. We're in the process of trying to re-record some of the old ones because the sound quality wasn't very great. Also, the Society offers support groups for people with early symptoms and for caregivers. We put out 2 bulletins and 1 newsletter. The newsletter is called Contact, and we also have an e-version of it, e-Contact. And then there's In Touch, which is a bulletin for caregivers. Insight, a bulletin for people with dementia by people with dementia. To subscribe to these, you can go online to our website, alzheimerbc.org. Or you can call the provincial office, and they will put you on the mailing list and send out hard copies. Provincial office, 604-681-6530, or toll-free line 1-800-667-3742.